their videos so that um, so for better interaction, so that we have better interaction with all the participants. And I request all the participants to kindly indulge in the discussion part and ask questions. And you can raise your hand and put your questions in the chat box as well. Thank you so much. Over to you, Shruti ma'am, whenever you want to start the session. Thank you.
So, because this is a new session, this is the first session for the new team, I think I would request Manas to start the proceedings.
Thanks, Shruti. I think we'll wait till 7 exact and then we'll start. We'll give everybody 1 more minute to join. Thanks, Tulika ma'am. Thanks, Chandra sir, for joining. Okay, I think it's exact 7. So, good evening, everyone. On behalf of Pediatric Hematology Oncology Chapter of Indian Academy of Pediatrics, I would like to welcome all of you. So, this is the academic program by the PHO chapter of IAP. It has been going strong for the last few years. I think the only good thing that COVID did to us was telemedicine and online education. And doctors have clearly adopted these two things in a good way. So, yeah, we have to see the good thing out of COVID that we got. So, welcome all of you. And we thought we'll start off this session by discussing some basic, very important topic. And for the 2 years ahead, we thought we will have to have hematology, oncology, both balanced in our academic sessions. So Dr. Banavli, myself, and the entire EB, we all will be trying our best to have an interactive, a versatile, diverse program for all of you for the next 2 years. And Shruti and Vasudev both are going to help me with the national program where our own speakers, our own people, their own experiences, they will be guiding us as to how we can improve our pediatric hematology oncology practice. So thanks, Shruti, for looking after the hematology program. Thanks, Vasudev, for looking after the oncology program. And this will be conducted on the second Thursday of every month from 7 to 8 p.m. and it can extend for some more time. Thanks, ECO, for providing us the platform. ECO, we have been using ECO for the last few years, and it has been going good. I understand that there are some hitches about getting the link much in advance, and they usually send it half an hour prior, and some of you do not get the link. So we'll try to sort out that issue as well, and we'll try that everybody gets the link, but we'll definitely put it onto the WhatsApp groups in case somebody is not getting the link. And you can please directly message us if the link is an issue. And also do check in your spam in case you haven't got that link. On behalf of PHO chapter, Dr. Banavli, I would just welcome all of you and move to the academic session. So Shruti, over to you to please take it forward.
Thank you, Manas. So the topic that we chose for today is addressing our deficiencies. It's an irony that on one side we are, talking of homegrown CAR T cell and on the other hand, we are failing to reduce the number of children who are suffering from anemia. So that's why we thought let's, start from the very basic. And I don't think there is a better person than Dr. Jagdish Chandra to talk about these deficiencies. Uh, all of you must be aware that the chapter came out with the guidelines to deal with nutritional anemia. And Sir was the the brain behind those guidelines. So without much ado, I think, Sir, we are all looking forward to listening to you about how we can make it better and how we can fight a simple disease like iron deficiency anemia in our country. Over to you, Sir.
Thank you, Dr. Shruti and Dr. Manas, for introducing the program topic and myself. Well, I think Dr. Shruti made a comment that uh, how do I share the screen?
So there's a green button at the bottom
Yeah,
saying.
yeah, I'm just trying to get to that. Yes, okay. Yes, all right. So the slide is seen now?
Sir, it's seen. We just have to make it in the slideshow mode.
Yeah, I'll do that. Okay, now it's in slideshow mode.
Yes,
Yes,
sir.
sir.
Perfect. Perfect.
Yeah, so once again, good evening. Let us begin with this topic of nutritional anemia, the diagnosis, treatment, and prevention. And actually, largely, this talk is based on that guideline that we published 2 years back, because that was a very big effort on the part of both teams from PHO as well as Pediatric and Adolescent Nutrition Society. So some 20 odd faculty members, they joined hands and put together their thoughts and their efforts in reviewing the literature. And interestingly, regarding these guidelines, it would be amazing to know that, as Mana said, that the online teaching has gone. In this guidelines, also all meetings were held online. No money was spent at all on bringing out these guidelines. So if you look at the guidelines, otherwise they at least have one physical meeting and the things are sorted out there. But here, so these are the and persistence of anemia that is bothering now more than it ever did, because as you learned, the CAR T cell, not only in the medical side, elsewhere also there is so much progress, but we haven't progressed at all as far as control of anemia is concerned. And this just I listed the programs. They were 1970s we started, and Anemia Mukt Bharat was the name given to this program in 2018, with very little change. Sometimes the the same wine in the new bottle, but at times maybe bottle changed and the wine also changed, but the impact did not change at all. The figures will tell you that. So NFHS 3 2006, anemia in 6 months to 59 months, 78%, which was almost 4 to 5% points rise from the previous NFHS. Then slight decrease, almost 20% points in NFHS 4, but then that was just a short-lived thing. In about 5 years' time, when NHFS 5 came up, it was 67%. And though Anemia Mukt Bharat envisages that we should be able to bring down the anemia prevalence by 3% point every year, but that is not happening. And etiology, of course, going by the CNNS survey, which was done from 16 to 18, the comprehensive nutrition survey from the India. And you can see here that uh, a large proportion of the anemia in pediatric age group is nutritional. 68% in 1 to 4 years, 50% in 5 to 9 years, and 10 to 19 years, 65%. So, and if we look at the etiology as far as these macronutrients are concerned, the isolated deficiency of iron may be the largest, but in quite a few subjects, the etiology is because of the deficiency of more than one macronutrient, maybe at times all the three macronutrients. And that is what the CNNS survey also showed. The blue bar showing the iron deficiency, but you look at the gray bars, vitamin B12 deficiency rising from the young age group to the middle pediatric age group, and then adolescents having very high percentage of B12 deficiency compared to 36% of uh, anemia due to iron deficiency. Uh, Sorry, for folate deficiency, 30% in B12 deficiency, and 20% only because of 21% because of iron. So a deficiency of all three macronutrients is important, but then by and large, it's the iron deficiency which is the most common macronutrient deficiency as far as nutrition anemia is concerned. So, trying to highlight in this slide that the iron deficiency does not only lead to uh, anemia, and this would also mean that when we are doing general pediatrics practice, maybe there are many PGs in this audience, they should know that when you come across children with breath holding spells, pica, febrile seizures, be aware that there is a good association with iron deficiency, and with breath holding spells and pica, there is causal relationship, and same febrile seizure also there are studies which have shown that if you do iron status of children with fever who do not have seizures and those who have fever and seizures, you will find that febrile seizure patient had more chances of having iron deficiency. Same with thrombosis, though there are several causes in pediatric age group, but if the common causes have been ruled out, in even in Western countries, iron deficiency has been found to be one important cause of thrombosis. Cognitive impairment is something which is the most worrisome thing, in fact, and this is proved beyond doubt that in young infants and children, the cognitive impairment that occurs in iron deficiency because of iron deficiency, it's even irreversible. So you can imagine that persistence of deficiency or development of deficiency of iron, not even iron deficiency anemia, is so much detrimental to the child's mental health. Similarly, developmental delay has been noted and socio-emotional impairment as well. So a whole lot of this a canvas on which you can see the iron deficiency leading to so much of problems. And currently, a lot of talk is there, and probably that is one reason why government is taking too much of interest. It is said that iron deficiency leads to loss of GDP. In terms of GDP, almost 1.5 to 2% is on account of iron deficiency. Because in adults also it leads to a decreased productivity. The physical output is goes down with iron deficiency and so on. So coming to the diagnosis and treatment in the pediatric age group. So first thing is defining the anemia. And here again, I would like to highlight that the recommendation currently is that we should continue following the WHO cutoff of hemoglobin, below which we label the patient as anemic. And this is why this has been written is that few years back, the CNS data was analyzed, and it was seen that probably in India, there is a large group of children, or maybe even adults also. There are some other studies and some studies in other countries as well. So these patients who are anemic, they so-called anemic because by the standards of WHO, they have not been found to have iron, folic acid, B12, protein deficiency, or neither malaria was contributing to it, or neither they were having any thalassemia trait. So what it was, probably it was hypothesized that probably we need to have cutoff of hemoglobin lower down compared to what we do with the WHO, this thing. So, but as of now, the national programs as well as WHO has recommended that all developing countries should continue using these cutoff for defining anemia. And these are in the table form. You can see that uh, the for definition of microcytosis, we use in adults and children above 10 years 80 femtoliter cutoff, while in younger children it would be lower, and up to 2 years we take a cutoff of 70, and then from 2 to 10 years one can derive this 70 plus age in years. Similarly, for microcytosis, serum ferritin, etc., these are the cutoffs which are there in this the guideline document. So important recommendation is that in most clinical situation, a presumptive diagnosis of IDA can be made based on the red cell indices and the blood picture suggestive of microcytic hypochromic anemia. It's not necessary that all cases of iron deficiency you need to do ferritin. Those who are going to practice in smaller cities, maybe ferritin is not easily available. So, but in such cases where you have made the diagnosis on the basis of peripheral blood picture or CBC, one has to remember that a response to iron therapy should be documented for the confirmation of the diagnosis. But in case you need to investigate, serum ferritin is the first test. In situation where ferritin results are equivocal, one can look at the transferrin saturation, and newer tests like the reticulocyte hemoglobin and hypochromic percentage of hypochromic red cells. These can be used wherever they are available. So serum ferritin is something which was recommended in these guidelines, and this is also like several of the guidelines, they were reviewed. 22 guidelines on the iron deficiency, they were reviewed in a systemic analysis, and uh, 22 of them, they had written the first test that you do for iron deficiency is serum ferritin. And WHO also strongly recommends using serum ferritin to diagnose iron deficiency anemia. These are the cutoffs, 12 and 15 nanogram, microgram per liter or nanogram per ml. That is under 5 years, 12, and more than 5 years of age, 15 microgram. Same cutoff have been recommended more recently by British Society of Hematology. But in presence of infection or inflammation, even if the ferritin is close to 30, so that also can be taken as suggestive of iron deficiency in children. Now, when we talk of iron studies, please remember that when we order iron studies to a lab, particularly in in some institution which is not in under your control, you would have to write what exactly you want. Iron studies not always include ferritin, so one has to be clear that you are asking for iron, the transferrin and the transferrin saturation, and the ferritin as well. So estimation of serum iron alone is not something which is required for looking at the iron deficiency, but that is done only to calculate the transferrin saturation or total iron binding capacity has to be done along with that. Now, this reticulocyte hemoglobin, that might sound a bit of newer test to some. So, in both the electronic cell counters of Sysmex and Coulter, this is there as RET-HE or CHR, and this indicates the presence of the iron in the reticulocytes, because in them it has been found that it correlates with the serum ferritin too well. But if you look at improvement in iron, the first thing to improve is the reticulocyte iron. So that is now being used as a very important test for diagnosing iron deficiency anemia, particularly if you are looking at conditions where chronic inflammation goes on, like the chronic renal failure patients, CKD patients, the nephrology teams are talking about retic HE in a big way. Now, notice here the last parameter here is RET-HE, and you can see that in these two cases, these are probably hemolytic anemia patients showing a lot of macrocytosis and reticulocytosis. So look at the RET-HE in one is 25.4, which is below the cutoff, and the other side it is 29.3, which is more than the cutoff for diagnosing iron deficiency of 29 is cutoff 28 or 29 in most of the literature. So, moving on to the treatment of IDA, two things important: identify the cause and correct it, and the oral iron therapy, because parenteral iron therapy for pediatric age group is very sparingly used for, very rarely used for the treatment of iron deficiency. So, identifying the cause is like even small things like inadequate intake, because the large amount of milk is being consumed. Poor absorption could be the cause, like celiac disease, or blood loss may be there, intestinal blood loss, or maybe systemic diseases where blood loss might occur. And then providing oral iron therapy in the form of a syrup or tablets. And one has to look at what salt, what dose, what is the periodicity of dose, duration, follow-up, and evaluation of non-responders. So the next few slides, we will discuss that. So ferrous sulfate, fumarate, these are the commonly used salts. You could also see ferrous glycinate or trisglycinate and ferrous glycine sulfate. These are available. And then iron polymaltose complex is marketed in a big way. But the commonly used salts are ferrous sulfate, fumarate, and gluconate. And oral route, as we all know, this is safe, effective, economical, and leads to rapid improvement in HB if administered in the correct dose and followed up appropriately. And it's, of course, convenient for the parents and well tolerated by most of the patients. So this guideline recommended use of sulfate, fumarate, or gluconate in a dose of 2 to 3 milligram, which is currently recommended dose, and not 5 to 6 milligram, which is still there in very standard textbooks. Uh, and the duration is like 2 to 3 months after the hemoglobin has been normalized, and this is actually to replenish the iron stores, and then the child should be put on the prophylactic iron therapy. Single daily dose may be divided if the GI adverse effects are there, and one needs to follow these children on 7th day and 14 days, depending upon if it is severe anemia, 7th day, or if it is mild to moderate anemia, then you can do the first follow-up on day 14. So why 2 to 3 milligram and not the higher dose is that with 3 milligram also the recent literatures are showing very good response. I have not shown you the data, but the response according to the authors was excellent. And the other thing is that the British Society of Gastroenterology in their guidelines, they have also mentioned for adults 1 to 2 tablets of iron that contains 66 milligram elemental iron, one tablet. So a 65 kg adult is getting say 2 tablets. Even if 2 tablets, that comes to 2 milligram per kg or so. Now the other issue is single or divided doses. So single dose administration ensures a long-term compliance. Administration in the evening after dinner improves gastrointestinal tolerance, and single dose leads to better reticulocytosis response. And probably the reason is that the fraction of the iron absorbed from the second dose of the day is much less. This is because of the hepcidin response that occurs with the first dose given in the morning. So the subsequent dose given in the evening, the less iron from that dose will be absorbed. So single daily dose is mostly recommended, but of course one can split it in 2 doses if there is the GI intolerance problem. Duration, I said, more than iron therapy for 2 to 3 months after HB normalizes. And then we should also know how to assess the response to iron therapy. That is, initial response is by improvement in appetite and general well-being that comes as early as a day or two of starting the therapy. Compared to mild and moderate anemia, the rise in retics is much higher in severe anemias, and the retic count increases, the peaks at 5 to 10 days, and thereafter only the hemoglobin starts rising. So when we say that the follow-up visit should be at day 7 or day 14, it does not mean that you look at the CVC or hemoglobin of these patients at day 7, but this follow-up visit should be used for assessing the compliance, whether the patient is tolerating the therapy, and whether there is clinical improvement or not. And simultaneously, one should utilize this visit for emphasizing the dietary diversity and giving proper diet to the child if it is particularly those children who are young and they were not receiving complementary feeding in a proper way. So this is how the hemoglobin response occurs. One can see that from the baseline to 8 weeks, maybe 4 to 4.5 gram hemoglobin rise can be seen. And most of the children at the end of, say, 8 weeks of treatment, they will have a normal hemoglobin for age. So if we have done that bit, maybe still some patients would be that who do not respond well to the treatment. But then we have to know when we say that the patient has not responded adequately to the treatment. So for this, a cutoff of 1 gram rise of hemoglobin from the baseline at 4 weeks in a patient who is having mild to moderate anemia, or with severe anemia at 2 weeks, if the hemoglobin has not increased by 1 gram, this probably is not responding to the oral iron treatment adequately. But one can see that if it is showing general improvement, there is appetite improvement, the otherwise activity of the patient is improved, then maybe a smaller rise of hemoglobin also. One can wait for further, say about 2 weeks, and then see if the hemoglobin has earlier at 4 weeks has increased just by 0.5 or 0.6 gram. One can look at another 2 to 4 weeks and see if now this patient has started improving. So if the patient is not responding, we have to evaluate for compliance and see that the dose prescribed was correct and the salt prescribed was correct. Then we review the history of intercurrent illnesses or infections and look at if the patient might be having anemia of chronic disease or chronic kidney disease, and evaluate for the conditions hindering iron absorption, particularly celiac in this part of the country is common, may be associated vitamin B12 and folate deficiency may be there, and that is hindering the response. And look for the occult blood loss, maybe cow's milk protein intolerance, Meckel diverticulum, inflammatory bowel disease. These are causes, and look for other causes of microcytic hypochromic anemia, particularly again beta thalassemia trait, and we should know how to differentiate beta thalassemia trait from the iron deficiency anemia. I think the one can look at the RBC count, the Metzer index, and RDW. So in beta thalassemia trait, the RBC count would be more than 5 million, while in iron deficiency anemia, the RBC count keeps decreasing with the increasing severity of anemia. So it would be less than 5 million. And if you divide MCV by the RBC count, then the Metzer index would be there. More than 13 would be suggestive of iron deficiency, and less than 13 would be suggestive of the beta thalassemia trait. And RDW is much more in iron deficiency. If you take a cutoff of 14, maybe iron deficiency would be more likely. And in beta thalassemia trait, since the microcytosis in beta thalassemia trait is genetically determined, there is not much of variation in the cell size. This entity, iron refractory iron deficiency anemia, this is being talked about in the recent literature. So this is something uh, which is a genetic disease, and that occurs because of the mutation, homozygous state of TMPRSS gene mutation. But then there are so many other genetic defects uh, which are there, and they all lead to microcytic hypochromic anemia. Like there is hypotransferenemia, DMT1 mutations, the transport and the steep mutations. RADA is there, defective iron cycling, aceruloplasminemia, and erythroid mitochondrial iron metabolic the utilization, iron utilization. These are other defects which are there, which lead to not particularly iron deficiency anemia, but microcytic hypochromic anemia, and that might be mimicking sometimes as the deficiency anemia. So this IRIDA is anemia with variable degree of microcytic hypochromic indices, low normal or normal serum ferritin, unlike the iron deficiency anemia, very low serum iron and transferrin saturation, inappropriately high serum hepcidin. If you have the facility to do that, one can look at this. Oral iron refractoriness as per standard criteria for evaluation, and presence of homozygous compound or compound heterozygous mutations of TMPRSS6 gene. So that is how one diagnoses the IRIDA, and the treatment is with parenteral iron therapy. So this is the algorithm which is there in this article in Pediatric Hematology Oncology Journal. I think this was in 2017 publication from PGI Chandigarh team. So moving on to macrocytic anemia, uh, again from the same guideline, the cutoffs are there for diagnosing the macrocytosis. Here you can see that more than 90 femtoliter for a child above 10 years is the cutoff, and for 2 to 10 years you can make a formula like 84 plus 0.6 into age in years. And so if you multiply this with, say, at 10 years, it would come to 6, and 6 plus 84 would be 90. So more than 90 would be the cutoff used for. And these are the cutoffs that you use for diagnosing folate deficiency, and by folate levels and serum folate levels and the RBC folate levels less than 100, vitamin B12 deficiency by less than 200, and homocysteine and methyl malonic acid. We will see where these tests are utilized. So the clinical features, we see that most of these cases would be vegetarian, uh, poor socioeconomic class, mostly they are undernourished, pallor is there, bleeding manifestation may be there, and some cases are there with the the tremors, the so-called in, infantile tremor syndrome in B12 deficiency. Other features are there which are important: developmental regression or developmental arrest. Even now, these cases are being reported. Other abnormal movements like choreoathetosis, microcephaly, cognitive impairment, mild liver and spleen enlargement, and bleeding in the skin and other bleeds might be there. And it's not uncommon that with bleeding as well as liver and splenic enlargement, Dr. Marva published a series about some 30 years back, and he wrote that these cases might mimic leukemia or aplastic anemia at times. Sometimes the picture may be dimorphic, and if you look at the RBC histogram, it might have double peak there. Yeah, so this might be suggesting that there is iron deficiency as well as deficiency of B12 or folic acid. And in the PS, one can see the hypersegmented neutrophils. So the recommendation for the diagnosis as far as the serum levels were concerned, that the both micronutrient levels should be done simultaneously due to close relationship in the metabolism. Uh, folate, serum folate levels would suffice mostly, but at times maybe RBC folate level may be required, and they need to be estimated if there is a strong suspicion, but folate levels have been found to be normal. So, if the levels are of the two micronutrients are normal, but still there is macrocytic anemia, and it is felt that we are dealing with nutritional anemia only, then one has to look at plasma homocysteine or methylmalonic acid level or both. And the homocysteine would be elevated in the deficiency of both the micronutrients, but it is the MMA which would be elevated only in B12 deficiency. So, and as far as talking about anti-gastric parietal cell and disease factor antibodies, these are routinely not recommended. Maybe in adolescents, if the macrocytic anemia has been found to be refractory, in those cases, one could look at these investigations. And same way, there was a time about 15, 20 years back when the the knowledge regarding pancytopenia occurring with megaloblastic anemia was just emerging. Most of us did bone marrow aspiration. But now, since the levels are available very easily, the pointers, if there are no other pointers to suspect the aplasia or leukemia, the bone marrow aspiration may be avoided in cases with the macrocytic anemia. These are the cutoffs, which I think we have seen, but uh, uh, one one has to remember that the deficiency, the lower levels, they define B12 or folate deficiency, but if the levels are not low, one cannot exclude the diagnosis of B12 and folate deficiency, and for that we need to do the homocysteine and MMA. This is new test, holotranscobalamin, and this is also at least in some labs this is being done. This is to identify B12 deficiency, and it in some studies it has been found to be better test than the doing these cobalamin levels. In fact, some national programs in Europe, they are using HoloTC and MMA as the diagnosis of B12 deficiency in the community. This I think we have talked about. So coming to the treatment of megaloblastic anemia. So even if there is discordance between the lab results and there is a strong clinical features of B12 deficiency, treatment should not be delayed. Mild to moderate anemia due to dietary B12 deficiency can be treated with oral vitamin B12. And we should remember that if you read Nelson or other Western books, you would, as they describe the B12 deficiency, the treatment, they start writing about the injectable B12. But here in our country and other developing countries, lot of B12 deficiency is on account of decreased intake. So this nutritional deficiency can be easily treated with oral vitamin B12. So initial parenteral therapy can be given in children with neurological manifestation or underlying malabsorption of B12 or severe anemia with pancytopenia, where a faster response is desired. And in patients being started on parenteral treatment after initial maintenance, after initial response, the maintenance therapy with oral B12 can be considered. So again, going to the duration of treatment, maybe 3 months for actually the treatment uh, of the B12 and folate deficiency is not as well described as that of iron, but still it's usually recommended that a 3 month duration would suffice for children, those who are having even neurological manifestations. Sorry, for children who do not have neurological manifestations, but for those who have neurological manifestation, a duration of 6 months should be there. Similarly, with folic acid. So, treatment of folic acid deficiency should be initiated only after excluding coexisting vitamin B12 deficiency. And if the tests have not been done, it's prudent to start B12 for 10 to 14 days alone and then add folic acid if you want to give to both the micronutrients. So, again, highlighting folic acid should not be instituted alone if vitamin B12 deficiency has not been excluded. So these are the various compounds. In fact, the B12 is available not only in injections, tablet syrup, sublingual tablet, nasal sprays are there, and transdermal preparations are also there. But the oral versus injectable, there is a whole lot of literature which is available now, and it has been seen that oral treatment is as effective as intramuscular administration in obtaining short-term hematological and neurological responses. These are all Western literature, and you can see the Cochrane review also had shown that. So, the basis of oral B12 therapy is that 1% of cobalamin is absorbed orally by passive diffusion, which is independent of intrinsic factor. And daily requirement is very little, 1 to 2.5 microgram. So if you give large doses, maybe these requirement would be met. And most cases of B12 deficiency in India are of dietary origin, so oral therapy can be very useful. So if you need to give injectable, start with a smaller dose of 25 microgram per kg by intramuscular deep subcutaneous or IV route for the initial 2 to 3 days, followed by little higher dose. And this higher dose can be used for 7 days for severe anemia, and then for 3 weeks in children with neurological features, and then followed by 100 microgram on alternate days for 7 days, then once a week, and then in younger children or small, the malnourished children, the dose has to be small. Now, one important reason why smaller doses should be started is that if you give very high dose to begin with, the lot of patients start having tremors and other abnormal movements. And that is because there is sudden availability of neurotransmitters which were there because of which were deficient because of the vitamin B12 deficiency. So that leads to irritability and insomnia and the tremors. Tremors are quite like what we see in ITS, but this might be at times bothersome. And the other thing is that life-threatening hypokalemia, probably more theoretical, but this is there because of the rapid hematopoiesis and rapid cell proliferation. There is intercellular shift, so there might be hypokalemia. Uh, Cyancobalamine and hydroxycobalamine, these both are available. And surprisingly, the American books write cyancobalamine, while in UK, the hydroxycobalamine is the preparation which is used. And methylcobalamin is something which is very easily available in the oral preparations in India, and that can be prescribed for the oral therapy. Folate deficiency mostly is treated with oral. That is for adults. The British guidelines of 2014 they said 5 milligram daily for 4 months, and in pediatric age group 1 to 5 milligram daily folate can be used, and higher doses can be used if there is malabsorption, particularly in celiac disease where malabsorption of folate is there. And when you put the patient on gluten-free diet, it would take some time for the absorption capacity to improve, maybe a little higher dose of otherwise if you would have used say a 1 milligram in a child of 3 years, one could use 2.5 to 3 milligram in such cases. So I think this is as far as the treatment of folate deficiency. This is how we assess the response. Uh, the important thing is to remember that there is reticulocytosis, but then with treatment, MCV starts decreasing, and the 50% increase in serum iron lactate dehydrogenase can be there in the beginning, but then increased retic count would be there, and correction of anemia would occur between 2 to 4 weeks only, as we see in iron deficiency anemia. So if there is failure of response, check the compliance, uh, rule out infections, including tuberculosis. There is some data to suggest that tuberculosis occurs more commonly in patients with B12 deficiency. Associated iron or other deficiencies would hamper the response, and whole lot of PPIs and the H2 receptor antagonist use is there, so that might be interfering with the absorption. So one has to look at whether these are the things. And pediatric age group, we have to remember there are other causes of macrocytic anemia, that is Roger syndrome or TRMA, thiamine responsive megaloblastic anemia. Then there are inherited defects of metabolism and inborn errors of metabolism of cobalamin, that is from cobalamin C, D, E, etc. These are all diseases which could be the reasons for failure of response of oral or even sometimes injectable therapy. So all nutritional anemia, if you are treating with the iron or iron B12 both or only B12 and folic acid, it's important to give dietary advice. All caregivers of all infants and children being treated for nutrition anemia should be counseled to improve the diet. And this diet, the most important is that exclusive breastfeeding till 6 months of age, and after that, age appropriate, adequate, diverse complementary food should be started. And milk intake has to decrease to something like 500 to 600 ml per day. And if there is bottle feeding, important is to stop that, and that would probably help in limiting the milk intake. Transfusion in nutritional anemia is very sparingly required, but then indications are if the hemoglobin is less than 4 gram or if it is 4 to 6 gram, but there is some achypnea or there is some cardiac decompensation signs, one could give a small transfusion of 5 to 10 ml packed cell over a large duration of 4 hours. And of course, cardiac monitoring is required, and one can use the furosemide during the transfusion in these cases. So just a bit of on prevention of iron deficiency anemia. It's important for all of us pediatricians to remember what we can do even in our hospital or office practice. So or iron supplementation is recommended for preterm and LBW babies, uh, continued in infancy until adequate iron from complementary food is assured, and the dose recommended is 2 to 4 milligram per kg per day of elemental iron. And this is the recommendation from the our group from PHO as well as the NNF of India also. And all children, this is a new recommendation. I think we have to see screened for anemia at 9 to 12 months. This is the time when the the child comes for the MR vaccination, measles and rubella vaccination. And here mandatorily one should check the hemoglobin, not only assessing for pallor clinically. And then at 5 years or adolescence, uh, then, of course, after you have completed the treatment, attach these patients to intermittent iron folate supplementation under Anemia Mukt Bharat program, and delayed cord camping. Of course, now it is a practice. And if there is one child in the family who is coming with iron deficiency anemia or nutrition anemia, look at the siblings as well. So maybe the sibling also might be suffering from the same, and even mothers, particularly in young patients of macrocytic anemia and maybe late infancy or uh, young child with iron deficiency anemia, mother's iron stores also may be less. That is why the anemia might have developed. So to conclude, all patients should be assessed clinically for anemia. Proactive approach, looking at 9 months. During the immunization visits, early visits, one should look if the patient is a high risk for anemia, like preterm and low birth weight, if has been prescribed iron, so he is continuing or not. Exclusive breastfeeding should be emphasized for 6 months. Then counsel for full treatment of iron deficiency anemia to complete the treatment for the duration that you have prescribed, and then assess the response to the iron, document response. If the biochemical tests have not been done, investigate for the cause of non-response, attach to AMB program for prophylactic iron supplementation, treat the underlying cause, look at the siblings. For B12 folate deficiency, as we discussed, a lot of patients can be treated with oral therapy, and most cases, uh, those with neurological and severe anemia may need initial parenteral therapy. So I think that is what is the end of my presentation. Thank you. I think I have taken a bit of more time. Thank you so much.
Thank you very much, sir. And it's truly very enlightening, the talk. I request Dr. Tulika ma'am to just take the questions if there are any. And I would request everybody to post their questions also in the meanwhile. Madam, for your comments.
So, thank you so much, Dr. Chandra. Sir has devoted his life to nutritional anemias, and this was a brilliant and erudite lecture. I don't see any questions at the moment in the chat box. Okay, so there is one question that's just come up. Why B12 to be supplemented first in case of combined deficiency? So I think Dr. Chandra already highlighted that. Dr. Chandra, do you want to just repeat that?
Well, I think when the hematopoiesis will improve, the whatever B12 is available, that would be diverted towards hematopoiesis, and this would leave bit of very little B12 for neurological functions. So neurological functions might deteriorate, and even if the patient does not have neurological symptoms, they might appear. That is what at least is theoretically described right from the pharmacology. We keep reading this, so that's
And
the idea.
the neurological symptoms may not be reversible. So that's why it's very important to not further precipitate or aggravate that. So I think that's beautifully been described. I don't see any other questions. Please do ask your questions for now. And as Dr. Chandra has highlighted, in more than 50% of the pediatric population, the etiology of anemia is going to be nutritional. And I think that's very important because these are treatable causes of anemia. And another very good move is that the Anemia Mukt Bharat has now reached out to pediatricians, hematologists, gynecologists, public health people. So I think that is going to be really important. And we hope that the new version of Anemia Mukt Bharat will look into this in a better way. Um, there are several questions on iron preparations. There's also a very important question on the alternate day dosing. So the iron preparations are many. The more expensive iron preparations have less GI side effects, but they are also less bioavailable. And that's why in a public health program, the salts that were recommended by Dr. Chandra, like the ferrous sulfate, fumarate, are usually what are gluconate are recommended. The more expensive ones don't necessarily have any advantage. The alternate day dosing is again based on the fact that you suppress the hepcidin when you're giving large doses of iron, and in adults there is definite data to show that whether you're giving alternate day or daily, there's no difference, and so you can in fact give alternate day to patients. In programmatically, we've discussed that they want us to continue to give daily iron for patients with anemia to make sure that there's good compliance. Okay, so there's a question on iron deficiency with sickle cell disease. And yes, there is a very large study of about 7,000 patients, so a really large study. And in that, they did find that about 20% of the patients with sickle cell disease did have iron deficiency. So that is something that you should look at. Sickle cell patients who are receiving blood transfusions may have iron overload, just like thalassemia, but many of the sickle cell patients can have normal iron levels also. There's a question on the diagnosis of nutritional anemia in children who are undergoing treatment for ALL. And so these patients may definitely have nutritional deficiencies. And I think that's really important to identify. Most of the time for patients who are on ALL therapy, they can get blood transfusions if they are truly anemic. And iron can be given if required. But I prefer actually to do nutritional counseling. And this is one of the things that I think is really important to remember, that we should not treat nutritional deficiencies only with the nutritional supplements, which obviously are required, but we also need to make sure that we do adequate dietary counseling, because even if you supplement and correct the deficiency, if you don't change the diet, then after you've completed the supplementation, the patient will go back to developing the nutritional deficiency again. And I think that is something that Dr. Chandra and I are talking to the Anemia Mukt Bharat people to make sure that they don't simply just treat the patient for a few months and then just leave the patient. You have to alter the diet. You have to look at the etiology of the anemia in order to make sure that this doesn't happen again and it doesn't happen in the other family members. Okay, so I think we can, I see that there's a message to stop, because we are moving on to Dr. Vasudev is going to be talking to us about the Anemia Mukt Bharat, and we'll take the rest of the questions after that. Okay, thank you.
Thank you, ma'am, and sorry for stopping you. We will keep taking questions after we've discussed the Anemia Mukt Bharat program. And for this, I would welcome Dr. Anupma Nair, who's a fellow at Apollo Cancer Center, Chennai. So Anupma, over to you, and then you can keep typing your questions. Also, for the fellows, if you want any specific topics to be taken,
Good evening.
to message Manas or me or Vasudev if you want to have future sessions on any particular topic. Thank you, Anupma. Anupma, you can start here.
Good evening, everyone. Ma'am, is this? Okay. Good evening, and I'm Dr. Anupama, fellow from Apollo Cancer Center, Chennai. And I would take this opportunity to thank the organizers for giving me this opportunity to present in this forum. And I will also like to thank Dr. Revati ma'am, Dr. Ramya ma'am, and Dr. Venkatesh sir for guiding me through this presentation. So I'll be talking on Anemia Mukt Bharat. This is the overview of my presentation. We'll have the introduction, the timeline, the objectives, who are the 6 beneficiaries, the 6 interventions, the 6 institutional mechanisms, what's new, and the take-home message. So what is anemia? Anemia is basically a condition in which the number of the red blood cells and the oxygen carrying capacity is insufficient to meet the body's physiological requirements. Basically, it is a reduction in the quantity and the quality of the RBCs. So it can be either because of B12 deficiency, iron deficiency, other hemoglobinopathies, but the most common preventable cause is iron deficiency anemia, which is addressed in this talk. So whenever the iron, the hemoglobin is less than 8 in all the age groups, except in children less than 5 years, and in pregnant women, the cutoff is less than 7. It is defined as severe anemia. When does anemia become a problem of public health importance is when the prevalence in the community is more than 5%. That is when it's 5 to 20%, it's of mild public health importance. If it's of 20 to 40%, moderate public health problem, and more than 40%, it's a severe health problem. So if we look at this data by the National Family Health Survey, we see that the children, adolescent girls, boys, women in the reproductive age group, pregnant women and non-pregnant women, all of them have more than 40% prevalence of anemia, which means that it is such a big problem in our country. So the causes of the anemia can be because of low iron use, that is in pregnancy, that is whenever the pregnant woman gives birth to a low birth weight infant, the infant will ultimately grow out to be a child with with iron deficiency, then the adolescent with iron deficiency, and this vicious cycle will continue. The dietary factors could be inappropriate infant and child feeding practices, especially if you give more of milk-based diets during the weaning period. And taking iron inhibitors along with the iron, like tea, coffee, if you take along with the iron tablets, and lower bioavailability of dietary iron, especially in a vegetarian-based diet. We know that the heme iron, that is which is found in the meat, it is more easily absorbed. But the Indian diet, most of them they take vegetarian diet, because of which it makes it less available. And the RDA, not taking appropriate RDA. Iron loss can be because of parasitic load also, especially in the villages when people do not wear appropriate footwear. There can be hookworm infections, which can lead to iron loss. Maternal anemia, that is increased iron requirement during the pregnancy, lower age of pregnancy, like teenage pregnancy. If there's no proper spacing between the pregnancy, that is at least 3 years, which is recommended, and it can all lead to postpartum hemorrhages, another complication which can again lead to anemia. The health consequences of anemia, again, it varies from different age groups. That is, children and adolescents can have poor cognition, concentration, memory, and school performance, and depressed immunity, decreased immunity, repeated infections, increased fatigue, and shortness of the breath. While adults can have low productivity, low physical activity, and can cause increased cardiac complications. Pregnant women can again give birth to like premature birth, low birth weight infants. They can have PPH. It can again lead to maternal mortality, perinatal mortality, neonatal mortality. While the same applies to lactating women, they can have more tiredness, breathlessness, increased risk of infections, which will again lead to increased stress and higher risk of depression. So, if you look at the timeline, what have we done to address this problem since the ages? That is, from 1970, we had the National Nutritional Anemia Prophylaxis Program. In 1991, we had the National Nutritional Anemia Control Program. 2007, we had the 12 by 12 initiative. 2013, the NIPI, that is the National Iron Plus Initiative. And in 2018, the intensified NIPI, that is the Anemia Mukt Bharat. Now, if we go to the Anemia Mukt Bharat, it was launched in 2018, complying with the targets of Poshan Abhiyan and the National Nutrition Strategy, which was set up by the Niti Aayog. Now, the aim of this program was to decrease the prevalence of anemia by 3% every year among all the different groups, that is the children, adolescents, women of the reproductive age group. Also, the government of India had a target of reducing the anemia among the women of reproductive age group by 50% by the year 2025. This is again based on the life cycle approach, which I had just explained. That is, an anemic pregnant mother will give birth to a low birth weight baby. The baby will become an anemic child, an anemic adolescent, and anemic women in the reproductive age group. So we have to target each and every person in this to break this vicious cycle. So the objectives is again to decrease the anemia by 3% every year. For this, we have the 6 by 6 by 6 strategy to combat anemia. That is, we have 6 beneficiaries and 6 interventions and 6 institutional mechanisms to prevent anemia. The 6 beneficiaries include children 6 months to 5 years of age, then children 5 to 9 years of age, adolescent girls and boys, pregnant women, lactating women, and women of the reproductive age group. Now, the interventions include prophylactic iron and folic acid supplementation, deworming, intensified year-round behavioral change communication, that is how to have a smart body and a smart mind, treating and testing of anemia, and mandatory provision of iron and folic acid fortified food, and intensifying awareness about the non-nutritional causes of anemia as well. So the first intervention is the prophylactic iron and folic acid supplements. It is to be given to all the age groups, irrespective of whether they have anemia or not. That is, children in the first 5 years, they get iron syrups, while all the others they give iron tablets. Pregnant women should take daily tablets, but for the others, it is just weekly one tablet. Now, if you go to deworming, that is yearly twice the patients have to be dewormed. That is February 10th. 2 days from now is the National Deworming Day, February 10th and August 10th of every year. So here, basically, we give 1 dose of albendazole. And in pregnant women, in the pregnancy, mostly in the second trimester, we prefer to give 1 dose of albendazole for them. Intensified year-round behavioral change campaign, that is how to make the patient more compliant to the iron and folic acid supplementation and deworming, and to teach them to have infant and young child feeding practices with age-appropriate complementary feeding, how to give iron-rich, protein-rich, and vitamin C-rich foods. And also, in all the health facilities, we have to promote delayed cord clamping at least by 3 minutes and early initiation of breastfeeding. Now, for a community and school level, we have to keep educating them in the youth festivals and special press advertisements, which is done on all the National Nutrition Day, the other important days. We have to keep educating them about iron deficiency anemia. Now, the if you look at the interpersonal communication, that is this is all present in the Anemia Mukt Bharat website. That is, there are various posters, various videos for educating the public about anemia. And next is testing and treating of the anemia, that is focus on the pregnant women and school-going children. So currently, we prefer to use more of digital hemoglobinometers compared to the previous ALICE method for a more accurate reading. So if we find any person to be iron deficient, we give a dose of iron for 2 to 3 months, and then we reassess, and according to whether they are responding or not, we refer them to the next higher center. Now, in some cases, we need to give parenteral iron therapy. That is, if there's severe anemia, moderate anemia in the second or the third trimester, if the patient is not compliant, or if there's any comorbidities and the iron is not getting absorbed, as in intestinal disorders and any chronic renal impairment, we prefer parenteral iron. Now, parenteral iron therapy, it could be either iron sucrose, most commonly ferric carboxymaltose. All these are used as parenteral iron. Now, the fifth intervention is mandatory provision of iron and folic acid fortified food, which is funded by the government. So, in the midday meal scheme and the ICDS, what they do is they use fortified wheat and rice, which contains iron, folic acid, and vitamin B12, and double fortified salt, that is salt which is fortified with iodine and iron, and oil fortified with vitamin A and D is used. Also, we should focus on the non-nutritional causes of anemia, especially in the endemic areas. The first one is malaria. That is, any person who's tested positive for malaria, we should look into anemia. And any person having anemia, we should check for malaria. And utilization of long-lasting insecticidal nets. We should also screen the premarital and the preconception, all the women for hemoglobinopathies. And women who have identified with hemoglobinopathies, we have to check their partners for the carrier status. And in case they are found to be positive, you have to offer them prenatal diagnosis before 20 weeks of pregnancy. And fluorosis, basically what it does is it damages the GI mucosa and prevents the absorption. So it is linked with anemia and malnutrition. Hence, a combined approach of safe drinking water and nutritional therapy should be taken up to treat the people with affected anemia with fluorosis. These are the 6 institutional mechanisms which I will be explaining one by one. One is the intra-ministerial coordination, that is Anemia Mukt Bharat Committee. It will have biannual meetings with the other committees, that is Ministry of Health and Family Welfare, Ministry of Tribal Welfare, Ministry of Women and Child Development, Rural Development. All these, they will work together. Anemia Mukt Bharat unit, it is in the national level, the state level, and the district level for the proper implementation of the program. Now, there is a National Center for Excellence and Advanced Research on Anemia Control, which is basically the AIMS Delhi Center of Community Medicine. It acts as an apex national body for anemia screening, and it provides technical inputs and policy making and program guidelines, how to make the program and how to guide and also support the sample chain monitoring. Convergence with the other ministries, that is coordinate with the other divisions of Ministry of Health and Family Welfare. There should be interministerial and intra-ministerial coordination, and strengthening of the supply chain and logistics, that is central procurement, and the quality of the drugs should also be maintained. Now, this is the Anemia Mukt Bharat dashboard and digital portal. Basically, what is it's a wonderful dashboard. It gives real-time data regarding the status of the anemia and the key performance indicators, which has been made available to the public. And what is new in this Anemia Mukt Bharat is coordinated management and efforts of intra and interministerial departments. And also, initially, what we used was 100 milligram of prophylactic dose. Now it is said that only 60 milligram is enough, and it reduces the GI side effects, and also it is made sugar coat to increase the palatability and hence the compliance. Communication materials for extensive awareness, that is creating a Jan Andolan, that is people's participation, people educating themselves and the others, and use of digital methods for hemoglobin estimation, also linkage with malaria, and mandate use of fortified food for public health programs, especially double fortified salt. Now, this is just the overview. That is 6x6 strategy, 6 interventions, 6 institutional managements for all the 6 beneficiaries. Now, the take home point is early detection of anemia and prompt intervention. It will help to break the vicious cycle. So, once we break the vicious cycle, it will lead to increased productivity of the individual, society, and hence the country. Thank you.
Thank you, Anupma, for that brief overview of Anemia Mukt Bharat program. I think I would like to ask Dr. Chandra sir and Dr. Tolika ma'am. Ma'am, as per this program, children and even, females have to be on iron supplementation lifelong. So how feasible do you think it is in any country for that matter to, take a medicine lifelong? And do you think that's a problem with the program?
Does Dr. Chandra, do you want to start, or should I?
Actually, this issue has been raised in some forum that for that long period you need to give iron supplementation, and even the program managers, they continue these programs year after year, and some kind of fatigue that also sets in. So there are issues like continuing the prophylaxis, but then since the anemia is continuing, there is no other way. That is, the recommendation still continues. But we have now realized that the earlier it was said that almost 70 to 75% the anemia which is there in the population, that is correctable with iron supplementation. But currently it's realized that it's not more than 50% that would get corrected. So that is why there is a focus on looking at the other things like say the hemoglobinopathies, particularly in India, this the sickle trait as well as the beta cell trait, there contributes. And of course there are certain states where malaria is rampant. There also the anemia is because of those things rather than just nutritional deficiency. But then as of now, this is the recommendation, and I don't know if Dr. Tulika has some more information on that.
Um, so thank you. I think your comment is very important. In my experience, we do have patients who have, especially women, who are chronically iron deficient unless they take supplementation. In fact, many times they'll take supplementation, then they'll stop the supplementation, and they'll go back to being anemic. So my philosophy on that is that we really need to encourage iron-rich foods, but unfortunately, because of the vegetarian diet and because of other social and other factors, many times people are unable to take an iron-rich diet, and so there definitely may be women in particular who may need to be on iron supplementation at least as long as they are menstruating. um, uh, but at the same time, most of the men, most of the children, if they modify the diet, it may not be required. So it's a difficult question to say on a um, you know um, uh, programmatic kind of a way. But in my clinic, I do have patients who will need to be on iron supplementation all their life, because we know that women who are menstruating have additional needs for iron, which may or may not be met by this. The other thing which I put into the chat box is that there are patients who have inflammation or recurrent infections and other things, and these are patients who will be refractory to most oral iron, and that is another group. And many times there's not much we can do for these patients if it is a incurable disease, or if it's like, we have many inflammatory conditions, and those patients again may need to get either parenteral or oral iron. So it has to be, I think, taken as a case to case basis. But the issue that we have heard in the meetings that we had with the Anemia Mukt Bharat is that even though it sounds like patients are getting iron for their whole life, but actually there are many programmatic problems in delivery, procurement, and many other things. So patients are actually not actually on iron for the whole life cycle as they should be.
So I think that's correct. Like there are so many issues in the supply chain, and in fact, when it comes to the school program, one has to coordinate. The health department has to coordinate with the education department. That is one. Otherwise, there's a study from this National Center. What is happening to the actual intake by the population? So they had shown that which used to be 7%, they say that it has increased threefold, but then it was 21%. So though threefold increase is good, but then that was also just 25%, 20% of the population was receiving the prophylactic supplementation. And then how much is getting consumed, that is another big issue.
So there are a few questions on B12 supplementation in the chat box. One is, what should be the dose for adolescent? Do we still stick to 25 to 50 micrograms when we start B12? And what is the regimen for infantile tremor syndrome?
So I think for infantile tremor syndrome, the dose could be, starting dose could be smaller because of the small weight of the child, but then later on, after a week or so, it could increase. Second is the adolescent can be started on a higher dose, maybe 500 microgram or so, because they would be treated more like adults. The per kg dose, I think one could have written the upper limit like 1000 and 1500. These are the two doses that have been used of oral B12 when in the Western literature. So that is something one can use in adolescents. There was one question regarding the use of parental iron FCM. If there is intolerance or reaction with that, could one re-challenge and or should be switch to other iron preparation like sucrose? I would feel that switch to sucrose rather than, because that is anyway much safer and easier to administer rather than re-challenging with the same compound.
Right.
Though I have very little experience with the using parental iron.
So actually, the ferric carboxymaltose can cause severe hypophosphatemia, and
Yeah.
that is one thing that before you're giving FCM, check the phosphate, because if the phosphate is already low, you can end up with severe hypophosphatemia, which will continue for up to 3 months, and these patients will complain of malaise, fatigue, body aches, cramps, and they can even have fainting. And whenever you're giving any IV iron preparation, check the vitals of the patient and observe the patient for at least 30 minutes after the infusion is completed, because many times the fainting, the hypotension, and all of these side effects can happen up to 30 minutes after the infusion is also over. So even though the intravenous iron preparations are very safe, but they all have side effects, and whether you're using iron sucrose, iron iso maltoside, or the ferric carboxy maltose, all of them can have the similar problems of anaphylaxis and all the other nausea, hypotension, and other side effects. And the iron sucrose is actually the only thing that is recommended in children less than 12. The other two preparations are to be given only for children who are 12 and older.
Right. So another question that I had, when we get these severely malnourished children with severe acute malnutrition and they have severe iron deficiency, hemoglobins are low. So does management vary in a child who has simple iron deficiency as compared to a child who has, severe acute malnutrition with iron deficiency?
Well, I think the treatment would remain the same, but one has to check that the levels, if it is, even if it is microcytic anemia. We had a study on SAM with anemia and supplemented them with the B12 as well. And we actually took two groups. One was that being treated on SAM management without extra supplementation is B12. So at the end of 12 weeks, we analyzed them. A lot of them had B12 deficiency. Then we analyzed the group at the beginning, and we supplemented B12 only in those who had B12 deficiency in addition to other micronutrient supplementation. So those who were supplemented B12, even they had at the end of 12 weeks some B12 deficiency, because with the rapid growth, the B12 gets utilized and the deficiency ensues. So they might be having borderline deficiencies, and the malnourished children would have all deficiencies, but maybe some is more and the other is less. That is how it is, and that is why the multi macronutrient mix is being talked about for the management of anemia, and not only the iron, folate, and B12. So similarly, in fact, the other two groups where we saw that the B12 deficiency increased with rapid weight gain was one was in ART center, the HIV patients. After initiating ART, their weight improved. But then if you look at their B12 iron folate levels, the B12 deficiency was more in them if they were not earlier supplemented. And similarly, the patient with celiac, one thesis I got done on B12, sorry, the micronutrient levels in celiac patients. So those on GFD, they had more B12 deficiency compared to those at the time of diagnosis, because celiac per se does not lead to B12 malabsorption. So whatever is there, that is because of the dietary deficiency. But the lot of GFDs are deficient in the B12, and recent literature is coming up that the patient on GFD, they should be given supplemental B12. So rapid weight gain leads to more problem in all situations. So I think the SAM patients have to be carefully looked at for the B12 supplement. In fact, we have written a small paper on the looking at micronutrients in SAM children, and not just the 10 steps, because the 10 steps does not include even the anemia. So 10 steps of management of SAM does not even talk of anemia, though they write later on some in small prints that if the child is anemic, give transfusion, etc. But then right in the beginning, you get the report and you look at that and act. So that should be highlighted. That is what we have mentioned in that. Thank you for that question. Yeah.
Right. And sir, about this timing of starting iron, because there's a lot of concern, even with mild URIs and mild diarrheas, iron is stopped left, right, and center. So what would be your take? When would you, start iron? Suppose a child who was admitted with some kind of infection to the hospital is getting discharged. So can we start iron right away, or we have to call the child at follow up and then start? Because I believe there is a window of opportunity that is being lost if we are not recommending iron then and there itself.
I think my understanding is that the viral infections, there's no problem in starting. It's the bacterial, and that too, if bacterial is like if you have given 4 or 5 days of antibiotics, that is good enough time when you can start if the things have improved.
Tulika ma'am, as the guidelines have suggested ferrous sulfate, but when you look at all the syrups that are available in the market, I was not able to find even a single ferrous sulfate which was available out of the government facility. Ferrous
Yeah.
sulfate is available in the government centers,
Yeah,
but
that's
there is no
Yeah.
ferrous sulfate syrup which is available anywhere. So how do
yes.
we, sort
See,
that
In
in
out?
fact,
in the
yeah, yeah,
private
yeah.
sector, you have to remember that the essential drug list drugs, there's advantages and disadvantages. Once a drug goes into the essential drug list, then there is certain price control that also happens. So many times, many of the companies are not very interested in making it. Only the companies that have like government contract will be making it because they can make their profits on volume. So you're absolutely correct. You won't you really don't find it outside the program. I don't know if Dr. Jagdish is aware of any. Most of the products that you're going to be available to you in the private sector and for us to consume outside programs are less bioavailable, more expensive. Um, but and that is the way that the thing is. I just wanted to comment on the infection part. So there is data on tuberculosis that at least if you have somebody with a known case of tuberculosis, you should actually start the ATT first. And, after about a month or two only, then you should give iron supplementation. So that is there for serious life-threatening kinds of infections. There is data to show that the iron can also be used by many organisms. But again, I totally concur with Dr. Jagdish that if it is a viral infection or if it was an acute infection for which you've already given the adequate course of antibiotics, then you can immediately start the iron supplementation because now the child is better. So try not to miss the window of opportunity except for things like TB, because there is data to show that patients who are given iron, their response to controlling the TB infection may be actually compromised. So that is something that we would not want to do.
So there's a question in the chat box about the efficacy of oral colloidal iron preparation.
Actually, all these arts are if effective. The ascorbate and colloidal iron and everything, they are effective, maybe plus minus 5%, 10%. But the main thing is that we have to realize that therapy has to continue for 4 to 5 months or maybe 6 months. So if you, even if there's a response in 2.5 months, so you continue another 2.5 months. So then it makes a lot of difference in the cost. So ascorbate, as I can tell you, compared to this fumarate and these preparations, is nearly 2.5 to 3 times costly. And same way, colloidal iron is there in tonoferon. I think tonoferon drops has colloidal iron, and
Correct.
that is a effective preparation. So it's not that it's not effective, but then the cost matters.
So,
So in the programs, if there was more funds, then they would probably use some of these salts because maybe compliance would be better. The Anemia Mukh Bharat actually has 3 different salts that are available. So they start with ferrous sulfate. In case there is intolerance, then they are allowed to switch to the fumarate or the gluconate. So that is there in the program.
okay. And so what about the folate levels? Like you've recommended folate levels, but when do you really ask for red cell folate? Because that's not available everywhere. The cost may be maybe an issue. So where would you ask for red cell folate, especially, and not a serum folate level?
Actually, most of the reviews showed that our recommendation is based primarily on that. But folate levels, as you said, red cell folate are very sparingly available. That is number one. The other thing is that if there is a strong suspicion that you will find that B12 is normal, the macrocytic anemia is there, then best is to look at the homocysteine and methylmalonic acid. So if methylmalonic acid is normal and the homocysteine is elevated, even if the folate is say borderline or something, one could say that this is folate deficiency rather than just thinking that the RBC folate should be done.
There is a British Journal of Hematology recent article where they've actually said if you're suspecting folate deficiency, there was a debate on whether to do the level or to treat. And what they're suggesting is the other option is you can give a therapeutic trial. So, in case you don't have the access to testing, one other option could be to give folate supplementation and see if there is reduction in the macrocytosis and improvement in the hemoglobin. So obviously, if best to always diagnose, but in case you're in a situation where you don't have the testing, you can also do that. One other thing I just wanted to highlight is that you can have iron deficiency without anemia. And that is something that we don't really think about because we already have this huge problem of anemia. But, that is something if you have your private patients or your patients that you're following, think about that too. And again, diet or iron should be given to these patients to prevent the sequelae of the iron deficiency, which can also lead to cognitive and other problems in the child.
Thank you, ma'am, for all the comments. And I think, sir, if any concluding remarks from you and ma'am, and then, we can call it a day.
Yeah, I think we discussed quite a lot, and every time I present, I also learn from experts like and Dr. Tulika, and maybe the questions also make you learn a bit. I mean, certain things which you are not conversant with much, maybe you look up again and be prepared. So, and I would thank Dr. Manas and yourself for taking up this as the first topic, and I am sure the balance with hematology and between hematology and oncology will continue. So all the best for the program, and thank you so much for giving me the opportunity.
It was an honor for us.
Thank you. Thank you, sir. Thank you, ma'am.
Thank
For
you.
all the participants, if you want any particular topics to be discussed, please send a message to Manas, Vasudev, or myself. And all these presentations will be uploaded on the YouTube channel. We'll share the link shortly so that even the previous ones, so if you want to have a look at again go through it so that the recordings would be available for all of you to go back to.
But the best way to learn is when you actually come to the program and listen to it live, because whenever you think I listen to this later, that probably that day never comes. So it's always good that you attend the meeting live and learn and ask questions. And this meeting is for you, so you all have to come and attend it live. That would be the most important message. We will have a special session for International Childhood Cancer Day. We let all of you know about that. We are starting an international speaker program very soon. We will let you know about that as well. And we'll try to go strong with the national program that has been going on for some time by the PHO chapter. So thank you, sir. Thank you, ma'am. Thank you, Shruti, Vasudev, and everyone.
Thank you and
Thank you.
good night.
Thank you, everyone. Bye. Good night.
Bye. Good night.